So I'm Dr. Khandker. I'm a neurologist and I specialize in epilepsy. Um, Mostly what I do is clinical work, seeing patients and taking care of people. My other sort of passion here is in education, so training our future doctors and also keeping our patients and our communities informed. So thanks for having me tonight. So we'll get started here.
You're a pro now.
Yeah, thanks. So tonight we'll talk about traumatic brain injury and epilepsy. It's mostly about epilepsy and sort of the overlap with traumatic brain injury. There's not much different about brain injury related epilepsy and other types of epilepsy. So first of all, what is a seizure versus what is epilepsy? So seizures are basically you have abnormal electrical activity in your brain that goes unopposed. So there's a very delicate balance of excitatory and inhibition that keep your brain balanced. And if one gets out of control, then you either have a seizure or you go into a coma. Epilepsy is when you have seizures randomly and without necessarily any provocation. Not everyone that has a seizure has epilepsy. Anyone can have a seizure under the right circumstances. Like if you are having, from drugs or alcohol withdrawals, or, if you're very sick, and that doesn't mean that you're going to continue to have them. So in terms of how we deal with it from the standpoint as doctors, usually we like to see one or two unprovoked seizures, meaning they came out of nowhere, there wasn't any obvious explanation for them, or you have one seizure and some kind of risk for having more, which we'll get into later. And then it's possible to have epilepsy and then for it to be cured or resolved. Sometimes with epilepsy will just go away on their own, not the TBI related type. And then some types of epilepsy can be cured with different treatments like epilepsy surgery. So how common is epilepsy? This is probably one of the top 5 bread and butter things that neurologists will see. One of the more common type of neurological problems affecting about 1%, 1.2% of the whole US population. So that's over 3 million people. In terms of the people that have epilepsy, they cluster sort of more on the young side, 20 and younger. So those people are the ones that are either born with it, either due to some sort of genetic issue or some sort of injury at birth. And then there's a big jump after the age of 60. And these are people who acquired epilepsy somehow through some kind of injuries, like a traumatic brain injury, stroke, cancer, what have you. It's some sort of injury that's caused it. That being said, in terms of this, what you'll notice in this pie of the different causes of epilepsy, the biggest ones making up 2/3 of the pie are this idiopathic and cryptogenic, which basically means idiopathic means it's a presumed hereditary, so presumed that you were born with it. Cryptogenic is presumed that there was an injury, but bottom line is we don't really know why it happened. So that's basically the majority of epilepsy cases. Generally, we'll consider a seizure as like a symptom. So it's not a disease in and of itself, but it's a clue that something's wrong. Like similar to like having a cough. So you have a cough, you can treat it, but it's better to get at what's actually causing it. So epilepsy is a bit of an exception in this case. In most of the cases, we don't know exactly what's causing it, but we can still treat it. And then amongst the cases where we do know what the specific cause is, that's about a third of the cases. Cerebrovascular meaning stroke, trauma, cancer, neurodegenerative diseases like dementia, Alzheimer's, cerebral palsy, and then genetic causes. So Bob has most of the cases, we don't know what causes it, but traumatic brain injury is definitely a pretty well-established cause. So traumatic brain injury, the risk of developing epilepsy down the line, that risk persists for decades. You can have an injury and then not have a seizure for 10, 20, 30 years later. So people that have the highest risk of developing epilepsy are the ones that have a severe brain injury. So meaning cracked open skull, bleeding in the brain. So those people over 30 years have a almost 20% chance of developing epilepsy, so 1 in 5. The more mild injuries, like concussions, those people also have an elevated risk of developing epilepsy down the line, but it's much less, about 5%. So more than somebody that didn't have a concussion, but relatively lower risk. So what does a seizure look like? So epilepsy and seizures are quite heterogeneous. It's similar to like cancer, for example. So if you say somebody has cancer, that's a really sort of non-specific term, and there's many different types of cancer, some of them are really bad, and some of them are really not that big a deal. That's true of epilepsy as well. So there's various sort of languages and terminology that we use to describe them. So this is just sort of an example to illustrate to you that epilepsy and seizures, they can look like almost anything. But the big clue is that the seizure will be stereotyped and episodic, meaning that typically it will look very similar or about the same every single time, whatever happened, whatever that event is. And it'll happen in episodes. So it happens and you go back to normal, and it happens, you go back to normal. They typically don't last more than a few minutes at a time. This word semiology that means the description of what the seizure or the event actually looks like. The truth is, like, there's a lot of other stuff that's stereotyped and episodic. So there's a lot of stuff that might look like a seizure, but it's not. There's a lot of stuff that you might think, oh, that's definitely not a seizure, and then it is a seizure. So it can be really tricky sometimes. What people mostly will think about when they think about seizures is the big one, the general tonic-clonic seizure, or what used to be called the grand mal seizure. And this actually, across the board, looks pretty similar for most people. So the first thing that happens is your whole body will get stiff. Every single muscle in your body is going to contract as hard as they can, including your diaphragm. So many people will have what we call an ictal cry, with the air getting pushed out of their lungs. And it sounds like you're getting possessed. It's pretty freaky. And then you have this tonic phase where every muscle in your body is tight, and you might have a little bit of a tremor, what we call dystonic tremor from the muscle, being pushed to its limit. If you ever lifted weights and you're at that, or if you're doing pull-ups or something and you're at your limit, your muscles start shaking or sort of tremoring, that's what might happen. And then it moves on to the clonic phase where your muscles alternate between contracting as hard as they can and then relaxing. And then, so these are big movements that we call convulsions. So they're very obvious, very dramatic and violent movements sometimes. During the tonic phase where everything is tight, this is a point where people will often bite their tongues or lose control of their bladder, their urine gets pushed out of their bladder. And then once all this is done, the seizure itself is done, your brain has basically spent all of its energy. It's like lighting a sparkler on fire. So once you light that sparkler, it doesn't start and stop. It's just going to go until it's burnt out. And that's what happens to your brain during a seizure. It just gets burnt out at the end of this general tonic-clonic seizure. So at the end, all of your muscles are relaxed, including your throat, your tongue. So people may have a very intense snore. They'll be, if not asleep, very confused, definitely won't remember anything. And it'll take, typically 30 minutes or longer, up to a couple of hours, to slowly get back to normal. So this general tonic-clonic type of seizure, this happens when the seizure spreads and is affecting your entire brain. There are types of seizures, so that's why we describe them as general tonic-clonic seizures. And then there's types of seizures that we describe as focal seizures, where it'll start in one part of your brain, but it won't spread to involve your whole brain. So those can be pretty tricky. Like I was mentioning before, there's a huge variety of how they might look, and it can be pretty tricky. Almost anything, as long as it's stereotyped and episodic, can be a seizure. The more common ones, though, are the ones that are involved with your temporal lobe. So typically, if you have or often when you have a focal onset seizure, you may have a warning sign that we call an aura. So the most common ones are sort of we describe as psychic auras, where you have a feeling of deja vu, or the opposite of deja vu is jamais vu, or feelings of impending doom. Often will be people who have that type of issue, they might be diagnosed with panic attacks, but really it's the beginning of a seizure. Can also have this rising sensation in your stomach from the seizure, causing your gut to sort of start squeezing. Those are pretty common warning signs, but it really just depends on where the seizure starts, what type of warning sign you may or may not have. And then the temporal lobe seizures that don't spread, often what they'll look like is automatic type of behaviors, like lip smacking and aimless picking, staring and unresponsiveness. The patient, if you have it, you don't remember it usually. So what you might experience is just lost time. You're doing something, they're like, oh, what just happened? And then sometimes even people will wander. So how do we?
Can I break in real quick? There's a question in the chat. So
Sure.
you mentioned seizures lasting more than 5 minutes would be bad. So we're kind of curious then. So what happens?
So often seizures that last more than 5 minutes won't stop on their own, and then you'll get into a situation that we call status epilepticus that can be pretty dangerous and usually is considered a neurologic emergency. So particularly with the general tonic-clonic seizure, if those go on for 5 minutes, they may just keep on going and they won't stop. And that's an emergency. And usually people may have to be put into a medically induced coma to make it stop. Thankfully, that's not very common. And we'll get into it a little bit more later in the talk.
Okay, so I have two other questions in the chat,
Sure.
and maybe we'll get to those in a minute. One is on focal seizures always appearing on EEG. And the other is on, I guess is more of a comment that focal motor seizures, if not stopped, will it progress to the whole body?
Yeah, good questions. I actually didn't plan on getting that deep into it, but we've got some informed folks.
We always do.
So the first question, you said, do focal seizures always show up on EEG? And the answer is no. This is more of a technical issue. The EEG, which I'll show you a picture of later, you have the leads on your head, and they're detecting those brain signals. Those brain signals, they get filtered out by your skull and your scalp and your cerebrospinal fluid. So they're very small. They're on the order of microvolts, whereas your muscle signals are on the order of millivolts, an order of magnitude higher. So you have to have a pretty large chunk of brain acting up all at once. So about 6 square centimeters, usually more like 10 square centimeters. So it's going to be like, a pretty big chunk of brain that has to be acting synchronously. So if it's smaller than that, then your EEG won't pick it up. So this is typically like the situation we'll run into with an aura or any seizure where you don't lose consciousness or awareness. Those are basically too small for the EEG to pick up. So you may not see any changes on the EEG. And then if the second part of the question was, if the focal seizure keeps going, will it spread? Typically it will, but it's really patient dependent. Some people have focal seizures that don't spread, and that's just how it is. So it's really sort of individual dependent how a person's particular seizure will behave. So some people have a predilection to going into status epilepticus. Every time they have a seizure, it just goes out of control. Most people, it'll spread. Maybe it'll spread it and involve the entire brain. Maybe it won't, but usually it'll stop on its own after a few minutes. And for some people, they may only have auras and it just won't spread at all. So it's really heterogeneous and individual dependent. So how do we diagnose epilepsy? So first of all, we need to have a convincing story that one or more seizures occurred that fit that diagnostic criteria that we talked about. Like I said, there's lots of other sort of episodic and stereotype things that can happen. So if the story sounds more like something like that, or if it sounds something that's not typical for a seizure, then we may need to consider that we're dealing with something else. And then the evidence that seizures are likely to continue occurring in the future. And that evidence we get from an abnormal electroencephalogram or EEG, or some sort of abnormality on your brain in terms of imaging. So the MRI or CT scans. So this is some people that used to work at OSU. So this is what a EEG setup typically looks like. The leads are glued to your head, and then they're connected to a computer that's reading the signals. And this is what the signals look like. What we're looking for are sort of what we can describe as short circuits that show that there's certain parts of your brain that are too excited and not being regulated properly. So I don't know can you guys see my pointer? I'm circling this part right here.
Yes.
And this is basically take my word for it, standing out from the rest of the normal EEG background. So seeing these little short circuits tell us that you have a risk for having seizures. And then seizures themselves will also have a certain pattern on the EEG. But usually we won't try to actually record the seizure themselves unless it's questionable, unless we're not sure we're dealing with seizures. And then in terms of the imaging, so this is an example of an MRI scan. What we have here is a picture of a scar from somebody that had a traumatic brain injury. So often people with traumatic brain injuries, they will have injuries to their frontal lobes or their temporal lobes over here, because this part of your brain is sitting in a groove in your skull that has some sharp edges on it. So if you get hit really hard, your brain gets jostled and it scrapes against the bottom of your skull and might start bleeding. And then also what you might see from the bouncing around, you might see like an injury on the opposite side from your brain bouncing around inside of your skull. The damage the type of injury that causes seizures, it has to be in the area that we call the neocortex, so the outer parts of the brain. Injuries to the deep parts of the brain don't cause seizures, because those parts of your brain are regulated different. So we need some sort of, so an epileptogenic lesion or like an injury that's potentially will cause seizures, it usually has to be more on the outside in the neocortex area. So how do we treat epilepsy? The first line is anti-epileptic drugs, and there's a ton of them out there. There's probably like 30 different ones now and counting. There's new ones being developed every year. They have all sorts of different ways that they work. So this is just a couple of examples of different medications and how they work. There's lots of them. Most people, about 2/3 of people, will be seizure free on the first 1 or 2 medicines that they try. So that's this chunk here. Maybe the first medicine won't work, but the second one might, or maybe the third one. But the more medicines you need to try, you get sort of diminishing returns. And so once you get to a point where you've tried and failed 3 or more medicines, there's like a very small chance that medicines alone will stop your seizures, about 3 to 4%. And so then we get to this group, about 1/3 of people who are considered medically refractory, meaning that medicines alone are not going to stop their seizures. And if medicines alone don't work, then we have to try other options. So there's other options out there that I alluded to before, like epilepsy surgery, various neuromodulation devices like the vagal nerve stimulator, the responsive nerve stimulator or neurostimulator, the deep brain stimulator. There's even minimally invasive types of surgeries like the laser ablation, and even certain diets can help with low carb diets can help with seizures. So some practical advice. So what do you do if you see someone having a seizure? Definitely what you want to do is stay with them. Try to time how long it lasts. Stay calm. Try to get dangers out of the way so that the patient, whoever is experiencing it doesn't get hurt. And then the more sort of urgent things is to make sure that their breathing is okay and to know when to call for help. For a lot of people that have known epilepsy, they may have seizure action plans in place. So people who have jobs or go to school, or people who have a lot of cognitive impairment and go to sort of day have programs or something, will often have some sort of written seizure action plan. And so that's important to know about if a coworker or a schoolmate or something has epilepsy. What you don't do, definitely don't try to hold them down, because that's just gonna probably end up with you or the person getting hurt. Don't put anything in their mouths, because these people who are having seizures, particularly the general tonic-clonics, are there's nobody home, so they're not going to be able to avoid choking on things, right? So to that extent, and even after it's done, like I said, people may be very confused or comatose afterwards. So you shouldn't try to give them any food or pills when they're out of it, because that will increase the risk of choking. You don't typically have to call 911. Like, as I mentioned before, most people, the seizure will end on its own in a few minutes, and then people will return to their normal selves within half an hour, or sometimes it takes a few hours. So the time that you want to call 911 is if the seizure lasts more than 5 minutes. As we talked about before, seizures that last longer than 5 minutes may not stop on their own. If they have multiple seizures in a row and don't go back to normal, especially if that's not their baseline, that sort of falls in the same category as status epilepticus, and that can be an emergency. People who have known epilepsy and there's something different about their typical seizures, then it's time to get evaluated. If there's any sort of injury, if they're having trouble breathing or choking, so this is one of the big risks that I sort of mentioned before, is that because they're not able to control themselves, they can't clear their throats. Often people who have big seizures, they may vomit and then breathe in their vomit, and that's a big risk to cause like pneumonia and choking. And if there's any sort of injury, so often people may fall during a seizure, they may dislocate a shoulder, they may hit their heads, they may cut themselves and have lacerations. So any sort of injury, if you're worried, give 911 a call. And if you think this is the first time that someone's had a seizure, so they don't have a history of epilepsy, then they have to be evaluated quickly to make sure that something dangerous isn't going on, like meningitis or a bleed. And of course, if the person asks, then you should call for help. That's all I have. So if anyone has any other questions, I think now.
All right. Well, thanks so much, Dr. Khandker. And we've got a couple questions in the chat. Again, folks, if you have questions, feel free to type them in. You can use the raise hand feature. Worst case scenario, if those aren't getting through or those aren't accessible to you, you can give me an actual wave and I can try and find you there as well. So a question in the chat from Dwight and Vicky. You mentioned no meds in the mouth. However, I carry a rescue med, clonazepam tab, for under my tongue that is placed under my tongue, and it's been very effective in stopping a focal seizure. So is that okay?
Yeah. So for patients for people whose typical pattern is to have prolonged seizures or to have clusters, often rescue medicines will be given. So what you have is a dissolvable clonazepam, the ODT version. So you won't choke on it because it dissolves, and then it gets absorbed like under your tongue. So that's okay. The other option that's out there, like if you need to give a rescue medicine to somebody who's out of it and can't take a pill, there's nasal spray versions of these rescue medicines. And there's also like a rectal gel that's usually used more for kids. It's not so practical to use in adults. So typically these days, what I will personally use are the nasal sprays, and I also use the dissolvable Klonopin as well. So short answer is yeah, that's okay.
Very good. Okay, so there's no questions in the chat. Okay, so Angelique has a question. Go ahead, Angelique.
Hello, thank you for this lecture. I have a question. I don't have seizures, but something happened to me one time, and I don't know if you, think this is a seizure or what this is, but it was an isolated incident and it happened like a couple months ago. I just had a really bad coughing spell. I have long haul COVID and I have a old brain injury from in a temporal lobe on my left side. But anyway, I just had a really bad coughing spell and I just couldn't get my breath. And all I remember is just like my legs kind of going stiff, and I lost track of time. I don't know what happened, but just I know the TV, it was like a longer time. But when I came to, or when I remember, I was just very like weak, that I just kind of couldn't move and just kind of felt dazed. But I don't know. It was just a very isolated incident. I don't know what that was, but I guess if it was a seizure, it wasn't a seizure, you can tell me what you think it was. But I just feel relieved that you said that sometimes they can be isolated if you're feeling sick or like coughing like that, and it won't happen again.
Yeah, and then I also mentioned that, sometimes it's tricky to differentiate if what happened to you was a seizure or something else. And
Yeah.
just from the story that you gave, it's very possible that it was something else. It's not uncommon for people to just pass out if they cough a lot and can't catch their breath.
Okay.
Hyperventilate. So that story that you gave, that one's not, it's not like really specific for seizures. So it could have been something else. And if it was isolated, it didn't happen again, then, you probably don't need to worry about it.
Yeah, sometimes I have coughing spells, but I never, that never happened before. So that makes me feel even better then. So anyway, thank you for explaining all these details and differences.
Yeah, my pleasure.
All right, Dwight and Vicky, you have a question?
I think you're still muted.
I'm sorry, I was on mute. Thank you. Very, very good lecture. I really appreciate the information. I was actually treated with a brain tumor through gamma knife radiation 18 months ago, and have had continued focal motor seizures through the last year. And the one thing that I'm trying to differentiate is the difference from a sensory seizure that leads to a clonic seizure in my right foot. And can you just talk a little bit about sensory seizures? I just have like a burning and tingling in that right foot. It's very intermittent, and maybe what potentially causes that. Yeah,
so tumor-related epilepsy, those are often very difficult to treat with medicine, and usually definitive treatment of the tumor is going to be your best bet. So going back to the focal seizures, mentioned that those can look like almost anything, and it really depends on where they start. So sensory seizures start in the part of your brain that's responsible for your processing of sensation, right? So chances are your tumor was close to that area. So when it starts, naturally the symptoms you're going to have are going to be the symptom, whatever that part of your brain is responsible for. So if it starts in the part of your brain that's responsible for processing sensation, then you're going to have some sort of sensation type of symptom. And even depending on where it is, you may have it in that sensation in one place, or some parts of your brain can cause like a diffuse sensation where you feel it everywhere. And your sensory area and your motor area, those are right next to each other. So often sensory seizures, when they spread, will turn into motor seizures as well. And so in your case, that seems to be what's going on.
Okay. Thank you.
I hope that answered your question.
Yes, thank you.
So just to make sure that we get some of this nomenclature down, right? So Deneen had a question, and honestly, I was trying to think, could I define this myself? So focal versus sensory seizures, does that relate to where it happens in the brain, or where it happens in the body overall, or is it a little bit more complicated than that?
Yeah, it's relating to where it starts in the brain. So that there's a lot of different sort of terminology that people use, and it's been updated, and so every couple of years, so people will so it becomes kind of confusing with the terminology, but most of it I think is pretty self-explanatory. So
and then for a focal seizure, I mean, I guess how would you define that? Like, because what does the focal component kind of mean?
So it means that it starts in one part of your brain, and it may
Just that it starts in one part. Okay. Okay, so Darcy has a question in here. I've had about 11 concussions. EEGs, MRIs, CT scans have shown nothing. I have undiagnosed simple partial seizures almost monthly. Might there be new technology or tests to help with diagnosis? Excellent question.
Yeah. So particularly with like something like a simple partial seizure, those are often too small to pick up on an EEG. And then in terms of the injury you might get from a concussion, also might be too small to see on an MRI, right? Usually when we get MRIs, we'll ask for a certain type of MRI with a stronger magnet. So the stronger the magnet that's used to get the images, the more detailed the images are. So on the horizon right now for like epilepsy diagnosis are use of 7T magnets, which are only used for research right now. Most MRIs use 1.5T magnets. Usually when we're working up epilepsy, we like to at least get a 3T magnet. That's one thing that's out there that's sort of new and on the horizon. There's various imaging techniques, MRI techniques, like diffusion tensor imaging that kind of will map your actual neurons, also used primarily for research right now. And then there's also nuclear imaging tests. So sometimes people who have normal MRIs, they may have abnormal PET scans or abnormal SPECT scans. That sort of stuff is already in clinical use, and we will often use that for people who are evaluating for epilepsy surgery.
Okay. Oh, go ahead.
And then the last piece of the in terms of other ways to, if you have normal EEGs, other techniques that are out there. There's a magnetoencephalogram, which is like an EEG, but instead of measuring electrical signals, it measures the magnetic signals, which are, because electrical signals all have some sort of magnetic component. So sometimes we can pick up on abnormalities using that if there's nothing on the regular EEG. And then there's also dense array EEGs. So you have, the typical EEG has 32 channels. The dense array has like much more, 64 or 128 channels. And sometimes we can pick up on signals that were not visible. So there's a bunch of stuff out there. That's typically not necessary to do that stuff unless you're being evaluated for an epilepsy surgery. Even if your EEGs and MRIs are normal, if your story sounds like epilepsy and the thing that's happening to you sounds like a seizure, that's usually good enough to at least treat it like a seizure.
Okay, so that's helpful. And I would kind of echo that a lot of the research that we do, which is the space that I work in, there is a lot of advancement in being able to detect these things, but it does take a lot of research. And what I wonder is, as you said, like you would want to get like a higher powered magnet. Those aren't always available. They used to be much more rare. Now they're a little bit better, but I think sometimes the availability of the tests can be challenging. Is that the case? Do we feel like that's getting better?
Yeah, I mean, at our institution, we have 3T magnets. It's a little bit easier to get it done. There's an availability issue sometimes. So we have a lot of resources here, but like if you live somewhere, you live far away from here, you go to like a smaller hospital, they may not have that stronger magnet because they just don't typically need it. Something like an MRI is like extremely expensive to, resource intensive for a hospital to maintain. So if it's not being used constantly, it's like very difficult for a hospital to justify even having one, right?
Yeah.
So we have a lot of patients here, and so our 3T magnets getting good use. Right?
Yeah, that's good. Okay, so then there was a question which I think goes along with all this, which is, will insurance pay for testing for seizures?
Yeah, usually that's not an issue. Now getting that advanced testing is, typically not going to be necessary unless you're not responding to medicine and you're being evaluated for an epilepsy surgery. And if you're at that point, yeah, we don't typically have problems with getting insurance to pay for this sort of stuff.
Very good. Okay, I'm kind of jumping around because we're going to run out of time, so I want to make sure I get to at least a few of the questions that are in the chat. So if you have had a TBI but not had a seizure, at least yet, is there anything that you can do to reduce your risk of having one in the future, especially given that that risk can potentially be over a long period of time?
Yeah, that's a good question. There's nothing that I know of. There's a lot of people who have like looked into like getting put on a seizure medicine early. And so what often happens in practice now is in the acute injury. So like as soon as you get injured and it looks like you may have epileptogenic lesion, like you're having bleeding in your brain or something, usually people will be put on a seizure medicine for 7 days to prevent those early seizures. And if you don't have a seizure in that time, then they'll just stop it. That's been shown to stop the early seizures, but not the late seizures. And that's pretty much the only sort of research that I know of in terms of prevention. Otherwise, I don't know of any even studies on preventing the seizures down the line.
Okay, so certainly an area of research that we can be ramping up.
Mm-hmm.
Okay, so then there was a question on dietary or nutrition factors, potentially like sodium or being dehydrated, a high carb diet, that could trigger those focal, motor, or sensory seizures.
Yeah, so very, very common provoking factors are dehydration and electrolyte derangements like low or high sodium. As far as the diet goes, it's not that high carb diets necessarily make seizures worse. Certainly having like extremely high or extremely low blood sugar can trigger a seizure in people that have epilepsy. Even people that don't have epilepsy, extremely high or low blood sugars can trigger a seizure. But for whatever reason, low carb diets seem to make it better if you have epilepsy.
Okay. There's a last question here. We got a minute. So how about Avastin or is it IV? I don't know. Have you used Avastin IV for treatment of tumor-based seizures? Maybe it's 4. If so, how successful it was?
Avastin?
Avastin.
Yeah, so Avastin is like a chemotherapy for brain tumors, or is used on a lot of other different types of tumors. So I'm not aware of Avastin being used specifically to treat seizures, but as I mentioned before, if you have tumor-related epilepsy, the best bet to make the seizure stop is to get rid of that tumor.
Makes sense.
Yeah.
All right. Okay, so I think that's kind of the questions that we have. I just kind of have one question, and this is going to be an unfair question. Okay. All right. I'm just going to get that out there right away. So, it just seems to me, right, not being a clinician, but also not being a patient or a survivor, right? So just sort of someone separately. It sounds like there's so much idiopathic, cryptogenic, right? We don't know why it's happening. We don't know which medication is going to take. There's a lot of things that look like it, but might not be, right? This is like undiscovered country. This is very challenging, probably both as a patient and as, a treatment provider, right? We're just trying to do the best that we can with the information we have. But you also said, if it seems like a seizure, if it's kind of got some of the basic, features of a seizure, that it probably is one, right? If the story sounds like it. So I guess I'm curious, does it take a lot of convincing on the patient's behalf or potentially on a provider's behalf, convincing or effort to get a diagnosis of epilepsy? And what could a person do to maybe make that easier?
Yeah, so it is a point of frustration for patients and survivors that sometimes the answer is just not clear. And we can do all of our tests and not have a clear answer. And this is sort of like the world we live in neurology. It's not just in the epilepsy world, but in with many neurological conditions. We're often, as you said, just doing the best with what we have. What I'll say is that sometimes it's a spectrum. So sometimes it's like pretty clear, right? You have like an obvious brain lesion, or you have an obvious, obviously abnormal EEG, or even if those things are normal, you have something that obviously sounds like a seizure, like it fits that script that I described to you before. Then it usually won't take much convincing for the doctor, at least. And as far as convincing the person that has it, that's usually dependent on how the information is presented, right? Which usually is predicated on how confident I sound as the doctor. So when I hear a story that's convincing and I'm pretty confident, and I instill that confidence on my patient, they'll usually trust that I know what I'm doing. And if I tell you, it's not really clear, then often, and with good reason, patients may elect not to try a medicine, which is a perfectly reasonable thing to do when it's not clear what's going on. So, so the short answer is, sometimes it's really straightforward and sometimes it's not. And when it's not straightforward, that's a really frustrating situation for both the patient and the doctor.
Okay, so let me flip the question and give you a fairer question.
Okay.
All right, so how do you feel like the field is going, right? So you're working with the best you got, right? We said, you know, some of these things are improving. You know, so for someone who has, you know, either had an injury, had seizures in the past, and is trying to manage that as best as they can, or, you know, someone who, you know, as Charlotte's question kind of alluded, you know, is concerned about this, but, you know, has not yet experienced it. I mean, how have things changed over the last 10 years? Do you see this going to a place where you feel more armed to be able to, you know, work through these issues with patients?
Yeah, so the answer is like yes and no. In some respects, you know, one of the reasons I got into neurology in the first place is because of rapid advancement, right? So I've been in practice for about 5 years. I've been, you know, my whole career from start to finish in training has been about 10 years. And just in that time frame, there's like, there's been, everything is different than it was in 2012, right? Everything is completely different. So that advancement is quite rapid. In terms of how people with epilepsy, so people with epilepsy have a lot more options in terms of treatment than they did 10 years ago even. But how well it's working, it's not really working that well is the problem. That this, you know, figure I showed you where about 1/3 of people are medically refractory. That was originally that, you know, the study that paper was published, a landmark paper in 2000, so 20 years ago. And then they repeated the study with all the new medicines that are out here 20 years later, so in 2018, they found the exact same thing. So needle hadn't moved at all. So all the new treatments that we had didn't change the fact that 1/3 of patients with epilepsy are still medically refractory. What I would say for those folks, the lowest hanging fruit is to help them is to get them to an epilepsy center to have an evaluation for something more aggressive, because all those, you know, of all the people out there, so there's, you know, 350 million people that have epilepsy in America. 1/3 of those people are going to be medically refractory, but only about 10% of that third are actually being seen by seizure specialists and being worked up for surgery, and the good candidates are getting the surgeries and getting better. So there's a whole bunch of those people are they're just not even being evaluated and considered for those more aggressive treatments. So
that's a pretty big crack then.
Yeah,
you have to try and fill.
So getting the word out and increasing the access to those, that's the lowest hanging fruit for making things better.
Cool. All right. Well, we were 7 minutes over. I appreciate everybody sticking around. I will echo the comments. Thank you to Julie for helping everybody get in. We had a little snafu with getting you the links, but now the link is there. You should be able to get in pretty smoothly each time. I want to express, just like everybody in the chat, thank you, Dr. Khandker, for a really excellent talk and working through a lot of these questions with us. You know, it's always a pleasure to have, you know, our physicians to be able to come in and do this. So thank you so much.
Yeah, thank you for having me. You know, I'm glad to be able to do it.
Great. Okay, so folks, just before you go, I just want to make sure everybody knows what's going to go on this month. So, you know, we used to do it for 3 weeks. We're going to be doing them 2 weeks. So we'll have our workshop this week. We're going to take a week off next Wednesday. Then we will be back the following Wednesday. So the 3rd Wednesday of the month, we will have survivor stories. If you didn't join us at the beginning, we're going to be continuing to do those survivor stories. They were a big hit last time. I think they will be again. We've met with the survivors who are speaking this fall, this morning. I'm really looking forward to sharing those stories. And I think that you will both enjoy and empathize and connect around those as well. So I'm definitely looking forward to that. If you have any questions, please email us and we'll make sure that you know where you're supposed to be, which nights and so on. And I will plug just very briefly that we are putting together an in-person session. While NeuroNights will continue to be offered online in any case, even if we do have in-person stuff, we want to make sure that it's accessible to you. But we are thinking about doing some social stuff this semester. And so as we get more information and have something to share with you, hopefully in the next few weeks, we will get that out there. But we're targeting November for that. And hopefully more after that. So some really cool things on the way. But until then, I guess we'll see you in 2 weeks. So thank you very much, and see you later.
Thank you to you all.
Thank you.
Thank you very much.
Thank you.
You're very welcome. Thanks so much.